that one step farther and evaluate the cardiovascular efficacy and designed the superiority trial, the SOUL trial, where we plan to enroll patients with type 2 diabetes aged 50 years or older with an A1C 6.5 to 10 who had at least one of the 4 eligibility criteria: coronary disease, cerebrovascular disease, peripheral arterial disease, and or chronic kidney disease. The trial was randomized, double-blind, parallel group, placebo-controlled. We used a group sequential design with one interim test for superiority. The trial product was added on top of standard of care, both standard of care for glucose management, but also for cardiovascular risk mitigation. And dose reductions and treatment pauses were allowed during the trial, with always through the trial trying to get patients on the highest dose tolerated as often as they could take it. We had selective safety reporting. It was selective because we know so much about the safety of semaglutide. We enrolled 9,650 participants. They were initiated on a low dose, 3 milligrams once daily at 4 weeks, titrated 725 first major adverse cardiovascular events defined as time to first cardiovascular death, MI, or stroke. This is the analytic strategy prospectively planned. The primary outcome, as mentioned, is the traditional 3-point MACE. And then if that was statistically superior, we had a hierarchy of confirmatory secondary outcomes comprising 3 different outcomes. First, we would test for efficacy for kidney-related outcomes with this 5-point composite kidney outcome presented on the slide. If that's significant, we would be able to test for cardiovascular death effects, and finally for major adverse limb events, including acute or chronic limb ischemia requiring hospitalization. And on the right, you see a number of individual secondary outcomes which were exploratory in nature, including cardiovascular outcomes, but also metabolic parameters. This is the flow diagram of patients in the trial. 11,150 were screened, ultimately selected baseline characteristics. I'll point out: age average 66 years old, 70% were men, average A1C was 8, and BMI was 31. And importantly, these patients on average had about 15 years diabetes duration, so very advanced disease. At the bottom here, so on average, it's important to understand in context of the previous flow trial in kidney disease patients. In this trial, it was relatively preserved kidney function on average with an eGFR of 74. And at the bottom, very importantly, also over a quarter of patients were taking an SGLT2 inhibitor at study entry, and up to 50% at some point during the trial were taking SGLT2 inhibitors. The primary outcome of cardiovascular death, MI, and stroke. This is the placebo rate, and you can see that oral semaglutide curves diverged within the first 6 months and continued to diverge throughout. A hazard ratio of 14% relative risk reduction with a p-value of 0.0028, statistically significant positive finding for 3-point cardiovascular death, MI, and stroke. Importantly, at 3 years, that was an absolute difference of 2%, yielding a number needed to treat of 50. The prioritized confirmatory secondary outcome of 5-point major kidney adverse events achieved a hazard ratio of 0.91, or a 9% estimate of relative risk reduction, but the confidence interval crossed unity. The p-value was 0.0967, so missing statistical superiority. So all data subsequent to this analysis becomes exploratory. This is the analysis of cardiovascular death, which was the second prioritized secondary outcome. Hazard ratio of 0.93, so again, directionally favorable, but not achieving nominal statistical significance with the confidence interval crossing unity. Major adverse limb events, the last of the confirmatory outcomes, again exploratory since we missed on 5-point composite kidney disease, a point estimate of 0.71, a 29% estimate of relative risk reduction, and here the confidence limits exclude unity, achieving nominal significance, but again, this is exploratory and a hypothesis generating. This was based on 170 total events to analyze. Secondary outcomes, as mentioned, the individual component outcomes of cardiovascular outcomes, adding now hospitalization for unstable angina, coronary revascularization, all-cause mortality, heart failure composite outcome, heart failure alone, a 4-point composite kidney outcome. All of these were directionally consistent with the overall trial findings. We weren't expecting to achieve significance for any of these observations, but we were pleased to see that this was a consistent directionally observation. Subgroup analysis of pre-specified factors of stratification by sex, age, BMI, A1C, eGFR, region of study entry, and SGLT2 inhibitor at baseline suggested consistency of the treatment effects across all of these subgroups, and importantly at the bottom, with or without background SGLT2 inhibitor, there is no differential treatment effect, suggesting that the treatment benefit of semaglutide is independent of what we would expect with SGLT2 inhibitor. Measures of metabolism, this supports the fact that the patients actually got the drug. Hemoglobin A1C, mean body weight, and mean high sensitivity CRP were all statistically reduced with oral semaglutide versus placebo. So in conclusion, oral semaglutide was superior to placebo in reducing the incidence of 3-point MACE in people with type 2 diabetes and ASCVD and or CKD. There was consistent cardiovascular efficacy of oral semaglutide across subgroups by sex, by age, by BMI, EGFR, and concomitant medication, and importantly by background SGLT2 inhibitor use. The overall safety profile of oral semaglutide in SOUL was similar to that observed in previous clinical trials with semaglutide, and no new safety signals were found. The trial results add to the favorable benefit-risk profile of oral semaglutide in this population. In final conclusion, oral semaglutide is the first and only oral GLP-1 receptor agonist with proven cardiovascular benefits. Further, and in diabetes care, we've updated the meta.
Moving from siloed systems of care to, again, more comprehensive whole body systems of care and recognition of cardiometabolic health for our patients. We saw earlier this morning with the STRIDE trial that patients with injectable semaglutide feel better, live longer, and now we're seeing this now with oral semaglutide. Again, those are exploratory, as you mentioned, but certainly improved cardiovascular outcomes. And I think it's so important for us as cardiovascular practitioners to recognize the vital role we play in moving perhaps beyond what we can traditionally think of as only our lane to recognizing cardiometabolic health more systemically. So again, congratulations. I'd like to point out a few things that you've already highlighted. One, the fact that 27% of individuals were taking SGLT2 inhibitors, as you mentioned, and I look forward to looking at that deep dive paper. I think that's important for those of us who may have had some reluctance in co-prescribing these medications, and the effects seem to be consistent not only with efficacy but also safety. This was certainly an enriched population, not necessarily representative of the entire population of individuals with type 2 diabetes, with 23% of individuals having heart failure, and I look forward to seeing those outcomes as well, where, of course, we've seen consistent effects in those patients with preserved ejection fraction, but those with reduced ejection fraction, there remains to be an outcomes trial looking at them, particularly with concerns around heart rate increase and otherwise. But really, it begs the question of where does this fit in our armamentarium? Is this reserved for individuals who are hesitant to the injectable forms?